Yes, yes, yes. And as someone said earlier, you know, that change tends to start with data. And traditionally, as Black people, we have been left out of that data. So I'm really excited about the next upcoming session that we're going to do on public health research and clinical trials, and what a world without racism looks like with that. What solutions can we have that would help to bring our worlds together? The you know, really nice health worlds of the MITs and Harvards and the Centauras and the NYUs and all of those, but also being able to come together with the Black population in a world that does not have racism. So I am excited to introduce Dr. Esteban Gershanik of Brigham Hospital, as well as Harvard Medical School, as well as Baljit Samra of Parexel. And they are going to give us an overview on public health research and clinical trials and what innovating with it for the future looks like.
Esteban, and you want to share your screen, or do you need me to share your slides?
If you could allow me to share my screen, that'd be great.
Okay, you should be able to do it.
Okay. All right, can you see it there?
Yep. Yeah, I can see this.
All right. Well, thank you so much. I just wanted to provide a brief overview. My name is Esteban Gershanik. I'm a med-peds hospitalist with a background in public health, informatics, and management. Previously served as the Chief Information Officer for the Louisiana Department of Health. And I'm very excited for this program. I just wanted to give a brief, broad overview of some aspects of hacking racism in public health research and clinical trials to set up an idea as to what data is out there and how to push some of this forward. So with that, I just wanted to give some background on some of these things. As has already been discussed, the mission of this hackathon will really be to figure out how to create a space for collaboration to dismantle the racial injustice in healthcare delivery and address the social determinants of health. Now, for those who aren't as familiar, public health, as can be noted by the CDC's website, is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. And I could go into the whole history, but that would take forever. But in the late 19th century and 20th century, there was a great dramatic increase in the average lifespan credited to public health achievements through vaccination programs, infectious disease aspects, safety policies, vaccination, sanitation, so forth and so on. A lot of it known on the risk factors of the society and individuals and groups. But despite these advances, racial ethnic minorities have suffered disproportionate morbidity and mortality from chronic diseases, including cancer, heart disease, diabetes, and stroke. Average lifespan of African Americans is 4 years lower than the rest of the population. Black women are up to 4 times more likely to die of pregnancy-related complications than white women, no matter the socioeconomic class, as we've seen with Serena Williams and other folks recently, with complications that they can get from their pregnancies despite all the resources at their disposal. And in 2002, the Institute of Medicine reported their document on unequal treatment, further delineating this huge, significant amount of research documenting the existence of health disparities. Now, with that, there's been a big push around social determinants of health, which, again, to define as by the World Health Organization, is the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, resources at global, national, and local levels. And they state that social determinants of health are mostly responsible for health inequities that we see between various races, ethnicities, so forth and so on. And these are unfair and avoidable differences in health status as seen within and between countries. For those, again, for a broad overview, for those taking part in the hackathon, these social determinants of health come from everything from your neighborhood to how your environment is built. Some areas have increased levels of lead, other components of their neighborhood that sort of has comprised issues with public health. There's health access and healthcare. There's a social and community context. There's basic education and economic stability. As we can see in the top 15 aspects of causes of death, there is a great percentage higher of Black death rates in various aspects of heart disease, diabetes, cancer, stroke, as you can see. And we also know, again, from the CDC website and articles written, how there is an increased chance of pregnancy-related deaths with Black women, American Indian, and Alaska Native women compared to white women. Furthermore, we know even just by your zip code, how you can have a difference of age of morbidity and mortality. First we see here is just based on the access in Washington, D.C., because I know we have some people here from D.C., how you can have a difference just based where you get off on the subway of basically almost 10 years to your life expectancy. And in my hometown, New Orleans, you can just be based on where your zip code is, 25 years of life expectancy. Furthermore, we have here in Boston, Massachusetts, an aspect that depending on where you live, again, your zip code, you can have a difference of as much as 32 years to your life based on that. A lot of these aspects based on old racial components of societal aspects and policies. And we can see there's amongst the top 50 cities in the US, a huge gap in life expectancy just based on your neighborhood. So what do we put together to really understand public health? So I put here a slide that came from an article that sort of brings in aspects of data that you need to understand how we can really hack racism and understand how we can figure out how to best do this. The idea of the physical environment that one lives in, the air and water quality, we can't forget about Flint, Michigan, housing and transit issues, social and economic factors, everything from education, employment, income, family and social support and community safety, clinical care, the access to care, the implicit biases that come with care, the quality of care, and health behaviors, including what's in one's community, so forth and so on. So there's no doubt, as delineated in this opinion piece in the New York Times, that there's racism hidden toll. Just basically where you live can delineate, where you live and the color of your skin can delineate how long you live. Many areas have declared this a public health crisis. And as we know, most recently with COVID-19, as many of you have seen in the papers and the articles, whether Black, Latino, Native American, and you can even access this if you go to the New York Times today to sort of see what is the morbidity and mortality on data today in reference to COVID-19 based on where you live and what your race and ethnicity is. Again, I'm just showing some brief data here on what it has been, what's out there. You can access this today from the CDC and even the New York Times. And there's been various articles showing this in different parts of the state and the cities that one lives in. And this depends on what data is provided. Again, not all data is provided. And when we try to hack racism, we have to figure out what data is out there in public health. Recently in the New England Journal of Medicine, there's been a couple of articles, one perspective piece on structural racism, social risk factors in COVID-19. Many of us already know these aspects of structural racism, the ways in which societies foster discrimination through mutually reinforcing inequitable systems, and how those social determinants of health, age, sex, birthplace, education, so forth, impacts this. And there's a recent article also in Louisiana about how the rates of hospitalization and deaths in Black patients were twice as high as though that would be based on the demographic representation. Furthermore, there was another piece of time to think big, which I'm hoping this Hacking Racism can achieve here with this event, in that COVID-19 mortality rates are more than twice as high in Black, Latinx, and Indigenous populations as white populations. And the data reveal a strong socioeconomic gradient. Beyond this, there's various reasons to this, as I just discussed. I don't want to harp too much so that we can go into questions and discussion around this. And to reach this, we need to think big. The one thing that, if anything, any disaster shows or pandemic is it takes off a Band-Aid on a deep-seated wound, and that's what we have now. Further articles have showed aspects of food availability, employment, housing, access to healthcare, immigration and documentation status, language one speaks, All this data are in different aspects of what you can find in different databases. And one thing to also consider, an article that also came out earlier this year, was the idea of hidden in plain sight, how basic race algorithms are inaccurate. This is anything from renal function. We recently, in the Mass General Brigham Institution, have gotten rid of their usually expected renal function based on one's race. And this article shows examples of when there was race correction used, when it ultimately would lead to a decreased referral to access to care for different specialties, whether it's renal function, whether it's birth, whether it's heart issues. All those are aspects that are ingrained in the healthcare delivery system and public health. So for those getting involved, you know, there's lots of data out there. One aspect is the CDC. This is all the data aspects that they have on their website. What you will see is while COVID has information today, many data sources are 2-3 years old or are surveys. So in considering what data you evaluate to hack racism, think about the accuracy of the data, how comprehensive it is, when it is around, whereas today you can access COVID-19 data because COVID-19 is a reportable disease. There's some data that's 2 or 3 years old, and understand whether the source is a survey or real data and how it is that we collect this information and how you can put it together. There's no doubt, as George Benjamin said, the executive director of the American Public Health Association, we do know that health inequities exist, and at their very core, they're due to racism. There's aspects we can address with this that I hope people can find out and figure out solutions to some of these inequities. And mind you, there's some cities and states that have already declared racism as a public health crisis. So with that, I'll turn it over back to the group, and I appreciate the time and look forward to the questions and discussion during this time.
Thanks, Esteban. Baljit, are you gonna be able to share your screen?
Yeah, let me pull up my slides. Ready, 1 second. Can you see that? Okay.
Yep.
Yeah, great. So thank you, Esteban. I think you set the context and the background very well, actually, for my session. And so my name is Baljit Samra. I'm a vice president and head of clinical operations, actually, for Asia Pacific, with a company Parexel that really focuses on clinical trials. So I'm going to talk for a few minutes really about some of the learnings we've been finding in terms of the diversity in clinical trials and some of the barriers there as well. And it will follow on nicely from Esteban's session as well. So really understanding the disparities and in clinical trial. Yeah, I'm gonna just put it into presentation mode and then move this up a bit. Sorry. Bear with me for a second. There you go. And then really talk about some of the data we've seen around the critical barriers to clinical trial participation, particularly from a Black and ethnic minority perspective. And then some of the areas we're focusing on to address these barriers as well. So you know, what we've seen in particular, you know, as a consequence of COVID, but also the racial justice movement in particular globally, but especially in the US that we're seeing currently, it's really accelerated the need to improve patient access and experiences in clinical research from a Black and ethnic minorities perspective in particular. You know, we've what we as an organization have been doing is talking to patients from Black and ethnic minorities globally to get their perspectives on what we could do better as an industry. And in addition to that, speaking to physicians from their experiences as well. And together, I think there's going to be a much stronger focus now as we build on the momentum to continue to develop partnerships between patients, physicians, industry, as well as communities as well, because you'll find that trust is an ongoing theme that has to be addressed as an industry. So, you know, what we basically found is generally you know, the fundamental question is how representative of the general population are clinical trials and the data compiled from clinical trials. And from a tough study in 2020, you know, we basically found that in over 4,700 trials, there was only 24.6% of participants that were from ethnically and racially diverse backgrounds. And that does not reflect the general population that will ultimately be using some of these medications when they're approved for use and so on as well. So it's so important to have as part of your subjects and participants in clinical trials a reflection of the reality of what you expect in terms of use once approved. So that diversity piece becomes really important going forward to ensure that population is represented and understand more through data on how patients may be impacted through the trials themselves. And so this, you'll see that basically, you know, the majority, almost 75%, were white participants, and then between Black, Asian, Latino, and other, it really came down to 24.6%. And so that the next couple of slides will really show what some of those barriers are when we dive into this in more detail. So, you know, fundamentally, you know, there's a mistrust of the medical community, and that seeps through a number of these different areas. So a combination of mistrust and then education, awareness, and then how do you transform that into advocacy and better understanding around the clinical trial process and the benefits about that. So, you know, mistrust, lack of clinical trial awareness, the comfort and feeling at ease through that, you know, some of the perceptions about being treated as guinea pigs, stigmas associated with certain disease types and so on as well, particularly within infectious diseases. We found from the physician session was that largely ethnic minorities find that there's a larger stigma associated with infectious diseases, and they're finding some of that seep into the COVID impact as well, and how the recruitment of patients into COVID trials in particular, just generally. And then you move into more the kind of socioeconomic challenges and logistical challenges around just having the time, financial constraints, geographical constraints, and then communication that translates into language barriers and truly having understanding and materials in particular translated into local languages and things like that as well. So there's a whole combination of things that fundamentally participants see as barriers for them to be able to partake in clinical trials. And then just what we've found from our sessions that we've had is really some of the areas we're focusing on. How can we address better? One is the lack of trust through identifying folks within communities who can serve as advocates to better educate patients and potential patients. The site staff diversity, so, you know, folks want to see people who look like them, who understand their cultural nuances or backgrounds in a much better way when it comes to kind of educating around the benefits of clinical trials as well. Patient outreach, how do you do that, but not just as a means to really kind of find patients at that time, but the emphasis was very much on establishing trust through longer standing relationships at a deep ground roots kind of community level as well. The practical barriers, you know, how do you help overcome some of the logistical elements, the social economic elements by you know, helping it make it easier for patients to partake in trials as well. And what we're seeing, particularly through the COVID impact and everyone having to suddenly kind of work from home as an example, you know, we're seeing a momentum now in direct to patient trials. So through technology and internet access, how do we make it easier for patients to take part in trials as well? And then translations and health literacy as well. So some of the solutions we're looking at is better engaging with participants from a very early age, part of the process, have their input factored into protocol designs and the practical elements of how do you actually execute on the trial as well. And then particularly from the patients themselves as well, there was an ask to truly make it easier from a logistical standpoint and have more and more home healthcare visits and access to the clinical trial by not having to travel for hours on end, or making it very difficult to get time off work and so on as well. So there was a whole collection of themes that have come through, and I think now it's for us as an industry to truly come together and think about how we collectively engage with the community, with patient advocacy groups, folks that influence within the community as well, be that religious pastors as an example. There's a famous barbershop study, for example, where they engaged with African-American barbers who helped to better educate African-American men on how to lower blood pressure. They monitored their blood pressure as well, and they're finding that through that engagement, they had better responses and better understanding now in terms of how to address a common health issue amongst African-American men. So I think fundamentally it comes down to trust and communication and what we can do collectively in order to respond to the momentum that we have now in society. So that's it. So Freddie, that was what I had today. So I'll hand back to you.
Thanks, Baljit. I'll turn it over to Esteban to kind of lead some of the discussion about some of these topics and kind of have a conversation. I think we do have a few of the Q&A if you want to use those, or if you have some initial topics that you want to hit on, Esteban.
Yeah, no, I think I'm looking at some of the Q&A. I think they also asked about the slides, so I'll leave that up to you. I mean, I'm happy to share any of this information. And I mean, I think the main thing I was trying to overview, and I think what's important to take into account is the idea of the long-standing history. I think one of the things with COVID-19, it sort of unmasked or took off that Band-Aid to things that we already know. And in some locations, you know, I see that Yusuf had asked, are they finally collecting on
Esteban, I think your connection is really breaking up here.
Can you hear me now?
Yes.
Can you hear me?
Yep, we can hear you now.
Okay, sorry about that. What I was saying is primarily the aspect of answering one of the questions in reference to the data. There isn't a complete standard in all states equally. There are some states that have more data than others. Furthermore, with different data sources outside of COVID-19, you'll see that sometimes it's just Black, white, or other, or doesn't have the demographic information. It depends on each public health entity what that data is around ethnicity and race. I can tell you when I was the CIO for the Louisiana Department of Health, all the data we had for our database collected around inpatient discharge data for the entire state had a dictionary that only stated for race they were collecting Black, white, and other. And so the question ultimately then is, if you're collecting data in such a way, how can you impact all the various communities across the state, including Vietnamese, Latino, and everything else that is very high in the community? So, I mean, I think in addressing the questions around what one hacks around racism and tries to figure things out, it's important to identify some of those sources and understanding some of the policies around why there is and is not data around some of this. And so I'll see what other questions we have coming through here. Another question we have here is whether there are any public data sets available in the healthcare space that include social determinants of health, like education and income. Around that, there's various different databases out there. So one is, as I mentioned, I provided a slide that showed access to the information that the CDC collects through social determinants of health, but there's also national databases around education and income as well. So I'd say not everything is in one bucket. Furthermore, you can sometimes reach out to ask for access to some of these databases for different states. And so I would say there's various ones both within the healthcare space and outside of the healthcare space that can provide you access. I don't know if someone else wants to, I'm afraid if you have any additional thoughts on how we want to guide this. I think the same thing occurs with the clinical trials as well, from what I understand around the data. I don't know if you want to answer some of those questions when it comes to clinical trials, if data is collected in a concrete or standardized way.
I think, Freddie, just to follow on from Esteban's comment there as well. I mean, I think that's where, you know, what we're trying to do from an industry perspective now is to engage representatives from Black and ethnic minority groups to help with the study design, as an example. So really get their input, whether it be as community members or patients themselves, and really see things from their perspective, and, you know, educate us in the process, but at the same time help us design the study so we're collecting the data in a better, more meaningful and consistent manner as well. So, but, you know, with that, then there's the barriers to overcome around trust, right? And how do you better educate people? How do you make the information aware of clinical trials, that they're available there? You know, often folks from these communities will trust only their provider. So how do you get that information out there as well? And generally, I think as an industry as well, we need to do a better job of getting the information on clinical trials and the awareness out there to the general public as well.
Some great comments. I kind of want to follow up with some of the comments that you made, Baljit, in your presentation. And one of them is, I think at one point you mentioned about the distrust or mistrust of underrepresented minorities and the research community, and especially in clinical trials. And there was certainly an article recently that talks about, you know, as much as the industry is trying to engage those groups to gain that representation, there's a serious concern about whether that population will also be prioritized once the vaccines come out, for example. Yeah. I don't know if you can talk a little bit about some of the ongoing vaccine trials and kind of the issues sort of surrounding that.
Yeah, I think fundamentally, you know, again, this is about how do you, in order to overcome the trust, how do you engage community representatives who are already trusted figures? So be that kind of religious figures, be it, you know, the barber shops, as I mentioned as an example. So folks who already understand it from the perspective of, you know, representatives in that specific community as well. But I think, you know, generally the industry, you know, does have to gain trust. I mean, it's been interesting, I think, with the response to COVID as a whole. You know, when you see some of the surveys that have been conducted, there's a better perception now of the pharmaceutical industry. But I think you know, it leads into everything from pricing issues to the historical issues as well. And we're, you know, as an industry trying to overcome that. But there is a long way to go, I would say. You know, that really fundamentally starts with better education and engagement and advocates within the communities.
Another question that's come up is, at least as I've talked to various people in the pharmaceutical industry, has been, yes, right now they're all saying that, you know, they want to get that bigger representation and improve that. But I think underneath it all, everyone is sort of also hesitant to be the first one to make their clinical trials adhere to some of those issues. And so, you know, because it's likely going to be, of course, at a higher cost to them and compared to their competitors. And so, you know, what are some strategies that can be thought of that will essentially get either industry partners to really come together on this, or is this going to have to be more on the regulatory side? And what can be done essentially from a patient perspective or from the individual perspective to force the community to really, you know, move forward in that direction? So that way, you know, there's not a, well, if the first person steps his foot in, that they'll be the first casualty, so to speak.
Mm-hmm. Yeah, it was interesting. We had a session with a pretty broad group of physicians not that long ago from both the African American as well as Latino community. And there was a couple of themes that came up. One was around, you know, how do you drive this fundamentally at the top of organizations, right? I mean, essentially leaning on kind of institutional racism, and how do you overcome some of these longer kind of historical aspects as well. So fundamentally, it was better representation from within organizations, so people and starting at the top, be it the boardrooms and kind of executive levels. So fundamentally, people who have a better understanding and representation of Black and ethnic communities. And then another interesting point that came up was, you know, FDA, for example, has had a guidance on diversity in clinical trials for a while, but because its guidance is not going to be adhered to necessarily, it will be considered but not necessarily adhered to. And should that be actual an FDA legal mandate that every clinical trial has to have a certain subset of patients that come from these, you know, Black and ethnic minority communities as well. So they were some of the suggestions there. I think those are certainly longer term aspects to aspire to, but I think we need to come together as an industry, and you know, certainly our organization is you know, trying very hard in terms of engaging now and trying to better understand so that we can fundamentally change things the way we've been doing historically.
And just to add to that, some of this doesn't happen overnight. There's long-standing history. So from Tuskegee to other aspects, and some of the institutions are trying to build community engagement with communities they weren't engaged with before. So we have a large trial at one of my hospitals that wasn't as involved with some communities previously. And it's a manner of being very careful with how you want to sort of take part in some of these clinical trials. And it's complicated. You know, I work and I live in two cities, Boston and New Orleans, two different dynamics. And even New Orleans, the presidents of the HBCUs there, of Dillard and Xavier University, got vaccinated, but it was a combination of support and against what they were doing around it. So this situation is complicated. It's not going to change overnight. And I think each city and institution is having manners in which they're trying to navigate how to properly provide representation, while also I'm hoping this will turn the corner on the dynamics of how communities and healthcare institutions and industry sort of, the relationship I think is changing overnight, and I think that's a good thing.
We'll take some of the questions from the Q&A here. The first one that comes up is, do you believe now more than ever that AI and machine learning could create models of missing data or predict realities for demographics that are not represented? And can these secondary approaches serve to build trust if PR'd well? That is to say, concerted accommodation for those who were previously left out.
I'll make two quick comments in reference to that. We know from this last year, some of the algorithms that were being used by United Healthcare and others, the AI was flawed because of what was represented and what wasn't, right? So I think if anything, we're uncovering how the whole idea of garbage in is garbage out, and how inaccurate data can completely flaw AI. And so I think, if anything, current conditions have allowed us to more constructively look at how we build algorithms to ensure it doesn't increase and further disparities and biases and racism within the algorithms that many institutions or insurers or other folks are creating. So I just want to make sure that that's something that's thought about when looking at AI.
Another question comes up in regards to clinical trials. Is it a priority to provide healthcare access to these underserved populations first in order to provide care, build that trust, educate ahead of expecting essentially that population to participate in a representative way in clinical research or clinical trials?
Yeah, I would say for sure. And then I think in some cases, and I'll kind of refer back to this physician session as well that we had, you know, so I think the perceptions also associated with certain types of disease or indications as well. So for example, oncology was coming up as an area of research where people almost expect the clinical trial to be a form of treatment that they could have access to, and there was less of a stigma associated with that. But what folks were saying was with COVID now, and similarly initially when AIDS first was had come out, was there the stigma associated with certain infectious diseases and the impact that may have within a community setting of not wanting to share kind of your you know, impacted by one of these diseases in a community setting and so on as well, played a factor into that as well. So I think certainly, you know, I think with the better education of clinical trials, we can start to better share that information and the fact that may be a solution of way of treatment as well.
So one of the questions that wanted to have you guys address too is, you know, obviously these are large and complex problems to try and tackle, and Esteban, as you say, you know, can't fix these problems overnight. What are some areas that you think participants and teams through a hackathon could meaningfully have an impact in terms of addressing some of these issues?
Yeah, I think traditionally, the public health system has worked in silos. If you see how the public health system is constructed at the CDC or in other locations, there is one department of, let's say, hepatitis, HIV, COVID-19, so forth and so on. And what would be great from, you know, there's a concept of syndemic, which talks about how the structural component of inequities impacts multiple diseases. And I think what would be great from the hackathon and how people can approach is using different data sets and incorporating them in a way to better understand how that affects communities in different areas, and taking a critical approach to the foundation of the data that's integrated into that data set. I know one of the questions on the Q&A, which I was just answering, was in reference to understanding whether the AI component that you discussed about, and the question is, you know, how you can understand whether the data you're putting in is going to cause some of those issues. And I think it's really taking a critical approach into looking at some of those data pieces, understanding where there are gaps, and identifying those gaps in order to sort of see how you can sort of complement each of those things to answer the broader, greater question that comes with some of these problems.
Yeah, similarly, Freddie, I saw one of the questions there about mobile health devices and how they can help, you know, improve in the clinical trial process. And what we're seeing now through COVID that's given us a lot of momentum is this whole space of kind of direct-to-patient trials, you know, decentralized trials, virtual trials, and so on. And it was really, you know, slow on the uptake, but as a result of COVID and then suddenly, you know, hospitals prioritizing COVID patients over clinical trials and so on, the industry had to respond to suddenly having to think about data collection in a remote manner. And so I think, you know, there's a lot of startups in this space now that are thinking about ways of using technology to better collect data and make it easier for patients in the process by having apps on their mobile phones and so on as well. So I think that's an area that we need to continue to drive as a trigger for change across the industry that will accelerate that change, and we want to certainly keep that up as well.
The one thing I would want to add to that, and one thing that we're seeing, is with the move to the virtual space, it can sometimes create an innovation. It sometimes can create greater disparities that are already there. You know, 20% of the Boston regional area doesn't have access to Wi-Fi, and 10% don't have cellular phones. So that's creating a greater disparity for the haves and have-nots with who can be incorporated and integrated into this broader market. And then the other aspect that has to be sensitively thought and taken into account, going back to the bigger question, is while we're talking about vaccine trials, healthcare delivery, some people are just thinking about, how can I pay my rent? How can I get food? And so I think we have to be very sensitive to know what the priorities are for many people who have been disenfranchised for years, for the entirety, and be sensitive to that when we approach some of these things we're trying to accomplish. Because, you know, we have food drives at different locations that I work at. Well, once you get someone to have food for weeks on weeks on weeks during these hard times, if you then come up and say, hey, do you want to participate in a vaccine trial? You have to be very careful when you approach such a subject, because it's like, wait, they're just trying to bring us in for food so that they can then do their vaccine trial. So some of those sensitivities have to be thought about, both around innovation and technology and the dynamic changes that are occurring in healthcare delivery.
Yeah, and it's really factoring a lot of that into the study design, what's suitable from that perspective as well. But again, you know, the point you just made, Esteban, is about fundamentally the trust, right? It's having had those relationships from a longer term perspective, so that you're not being seen as somebody coming in and trying to take advantage of patients for trials and so on.
And the other thing I'll challenge folks to, this is just my own bias, just I'll put that out there, being someone who's been around a lot of international people, is I think sometimes there's simplified buckets, right? Black and white. Well, I was at a Black Women's Life Matters convention last year, and a Dominican lady came up and said, hey, am I Black or am I Latina? Which bucket are you going to put me in? And so I think we have to be understanding of how we have to think about the more complex issues around, you know, in where I work in Boston, there's Haitian Creole speaking Black people, there are Spanish speaking Black people from different countries. And so I think we have to make sure we also don't oversimplify the issue, and make sure we look at broader questions as well, because if we collect the data in a way, understanding people's languages, we can then be able to communicate and outreach to them in a better way as well.
Yeah, so there's a question here that was asking, how does disability play in terms of research trials, and how do we make sure everyone is represented and not just able-bodied people of color? And I'll actually broaden that topic, that question a little bit more, because one of our tracks is going to be focused on intersectionality between not just race, but also other underrepresented demographics or minorities. And so, you know, whether that's gender, whether that's ethnicities, whether, as this question brought up, disabilities, how do you now weave in that additional layer of complexity on these issues?
Yeah, I mean, being the son of a father who's disabled, who got a spinal cord gunshot wound at an early age, who can't get around much, and as part of I'm part of the Brigham Health COVID-19 Diversity, Equity, and Inclusion group, that in our response, our leads include folks who are looking at accessibility. And so access means, are there appropriate ramps for disabled people who can't get access to certain locations? And there's a lot of policies that we can look at nowadays. There's some great work that was done by, I don't know if anyone's familiar with Steve Gleason, who was a former football player who helped pass legislation to ensure that people can get, ALS patients can get access to ALS machines so they can properly communicate. I think this has to be looked at comprehensively around all abilities. I don't call them disabilities as much, but people of all backgrounds and abilities. And we have to take a comprehensive approach to looking at how access can impact everyone and improve on that.
one of the questions around, I think, clinical trials, especially, or just even on a public health level, everything is very much a top-down kind of mentality and approach. What are some ways where we can essentially, especially as you mentioned, Baljit, in terms of how clinical trials have now become more decentralized, there's now remote monitoring, but how do we invert the process a little bit so that we can better crowdsource and better do sort of grassroots components of whether on the public health side or on the clinical research side to accelerate these processes?
Yeah, I think certainly the community engagement, right? And again, it comes through the education and awareness program. Like, how do you start to build and forge those relationships, whether it's through advocacy groups? So as an example, in one of our sessions we had, one of the physicians had said, at times of like Breast Cancer Awareness Month, for example, use that as an opportunity to go into communities and encourage the raising of awareness, and then build off that momentum you pick up, at those kind of community levels, really, and then factor that in, from that perspective onwards.
Let's see. So Jessica's trying to clarify her question is, how do we make sure clinical trials include people with disabilities and not be excluded because of criteria around health or assumptions of ability?
And I think that's sometimes a difficult question for multiple reasons. So in doing a study, sometimes the construct of the study won't have a high enough number of folks with access or disability issues. And I don't know if that is part of the limitation there, but I think I agree, we still have to figure out a better way to include such diversity in trials to ensure that we have an equitable approach, or equitable approach to how we evaluate all these needs of our population.
And then when you're designing the clinical trial, they'll have a clear set of inclusion exclusion criteria that will drive then the patient populations that you're looking to recruit.
And Freddie, you'd also said about a top-down approach. I think one of the things that has been great that I've been able to experience over the years is a robust patient family teams that are part of different hospital systems. I think hospitals have to do a better job of expanding the communities that speak up and represent patient populations equally, to provide the voice to the institution to help them understand what the needs are, to help mitigate that top-down approach and be more community involved. And there's some scores now for community engagement for hospital systems, which is interesting, showing that if a hospital isn't as engaged into their community, it sort of shows where they are from an A to F based on such components.
I'm kind of reminded of the question that Emory had brought up in one of the prior sessions, in Esteban, especially since you work at the Louisiana Public Health Office. When these more and more public health departments are calling systemic racism a public health crisis, what exactly does that mean, and what are some actions? What are actions that they're looking for either the community or the hospital systems to do in addressing that? Like, how does that change the infrastructure or our approach to it?
That's a great question, Freddie, and that's one I've spoken to a lot of my colleagues about. Many people have been hesitant to state racism is a public health crisis if there aren't action steps. And can you hear me there? Sorry, it looks like I went out a little bit.
Yep.
So I think if there's a clear action plan on how to address racism, it's a good point of pushing that forward. If it's one just for the namesake of it, I think there's some disillusionment at times of knowing what is going to be the follow through on it. And so I think one of the components of data is accessing data. And so the question sometimes can be around considering racism is a public health issue, is what some cities, counties, and states have done is they then created a multidisciplinary team of people from the community to say, hey, we're now going to collect data on social determinants of health. Hey, we're now going to collect data in a standardized way. And I think that's a follow-up step to at least address the issue and then move that into tangible actions based on the data collected.
Yeah, so another question that's come up is, as a result of proliferation of online, remote, or digital approaches where there's now increased online engagement, meetings, community development are valid and real because of COVID, but now balancing what are the ethical implications? Can online community development and engagement play a role as an equalizer and also provide greater context to fill in the gaps, and not only quantitatively, but qualitatively?
There is no doubt the impact of community health workers, and I think some of the coaches and some of the innovations that have been pushed forward have shown improved results around things such as blood pressure control and other aspects of how social media community groups and community health workers can help out within some of that realm. So I think that is a space that has a lot of potential to help connect with patients and their community and have a supportive track.
Maybe sort of a related question on, especially following up on the ethical aspect is, how do you, what is the end goal, right? What is a balanced representation in clinical trials, that component? Because so the question that was also being asked here is essentially, clinical trials involves human rights issues. Do you think that vulnerable populations more likely to be part of medical trials looking for monetary compensation, or because they don't fully understand the risks? So, yes, we're trying to get as much equitable representation as possible, but then do we risk running into that ethical component of sort of overcorrecting in that sense, and then, having issues on that side?
Yeah, I mean, I think it's, so what we've found is there's certainly the financial constraints that often play into this as well. So folks who, often single parent families, they're not able to get time off work or, find someone to take care of the kids. So there's a lot of those aspects that play into it. Then the geographical constraints as well. As Esteban mentioned, a lot of people from a socioeconomic perspective don't have access to internet and so on as well. And so I think we have to balance all of these aspects and make it fundamentally easier for patients to take part, and at the same time better educate them on the benefits of taking part in a clinical trial as well. So it's not just a financial or they can't see it as just a financial imperative to take part and earn some money. They've got to see the broader benefits of this from a healthcare standpoint.
I think I'll close off with one last question, and it's a little bit also related to what MIT has been doing. As some of you may know, MIT created its new College of Computing that launched about a year or so ago, and it wasn't really just focused on AI and machine learning and that implementation, but there was also a distinct focus on, what are the ethical ways that we develop AI and machine learning in our society. And I think speaks really plainly to this question from one of the attendees here. Says, at what point is AI helpful in clinical trials? Does the world of clinical trials believe in AI and machine learning implementation? But what are the kind of biases that we're looking at when it comes to selecting data from different races? So can you maybe give some brief comments about, how do you responsibly and ethically build AI and machine learning, especially when, obviously every data set is not perfect in that sense?
Yeah, I mean, there's certainly a lot of focus now on AI and machine learning, both from a speed perspective, but also having better access to data that can show you, in terms of data trends, in terms of helping with study designs and so on as well. But it's, so I think, you know, whilst there's a lot of focus in this area as well, there's still a lot of work to do as well. So, you know, what are the data sources that you're using? What's the quality of data like there? So as Esteban mentioned, in terms of silos as well, we're finding that the data is very siloed as well, right? So the ability to integrate that data, get the interoperability, then the quality of data, because historically we've never had good governance of data either. So how meaningful does it become as well? And there's a lot of work still to be done, I think, in this space, but it's definitely picking up momentum, and I think the reasons are right for that as well.
Great. Well, thank you so much, Esteban and Baljit, for this really great conversation. I think we've covered a large amount of ground here in this discussion. And with that, we'll transition to the next session. So I'll turn it back over to Angel.
Thank you. Thanks, Freddie.
Thanks.